Good evening, everyone, and welcome to today's Fireside Chat, Series 192. And today we're going to again delve into the pragmatic series. We're going to have a very interesting topic on kidney supportive care. My name is Dr. Yuri H. I'll be your moderator for this session. So today's topic is going to be on inspiring action in kidney supportive care across Kenya. Through a chain hub and spoke model. And our speaker will be Erin Das, supported by Cillian Gaki, and we'll also have Nixon Kiprono on the line. And they're going to share quite a number of cases, so it's going to be an interesting one. So just a little bit about our speaker, Erin. She is a Canadian advanced practice registered nurse. She's licensed in Canada and the US. She currently lives in Nairobi, Kenya, and she has 17 years of experience in palliative care. Her nursing and leadership experience includes pediatric palliative care, pain and symptom management, cancer care, community-based home care nursing, health education, and community development. Currently, Erin is the supportive and palliative care lead at Africa Healthcare Network, implementing the kidney supportive care program in AHN dialysis clinics across Kenya since December 2023. In 2023, she also joined Global Treehouse Foundation as a practice lead, focusing on improving access through scaling care and support for children and young people with life-limiting and life-threatening conditions and their families globally. In 2024, she completed a Master's of Nursing at the University of Calgary. She is an executive member of palliative care in humanitarian aid situations and emergencies, chairing the communication working group since 2022. She is a board member of the Nairobi Hospice since 2023 and a therapist at Faraja Cancer Support Trust, coordinating a cancer caregiver support group since 2020. She was a technical advisor with Kenya Hospices and Palliative Care Association, focusing on nurse leadership development from 2021 to 2022, and a faculty member of the current My Child Matters grant in Kenya, spanning from 2023 to date. This aims to improve access to pediatric palliative care in Kenya. She has lived and worked in 6 different countries, including Canada, Tanzania, USA, Bangladesh, Papua New Guinea, and now Kenya. So welcome, Erin. I'm looking forward to an enlightening session. You can take it up from here.
Well, good evening, everyone. It is really exciting to be here, and I'm really excited also to be working with some great colleagues at Africa Healthcare Network as we share about some updates in the work that we're doing in the kidney supportive care team. So as Dr. Yuri mentioned, myself, as well as Cillian and Nixon, will be speaking to you over the next half an hour or so, and we also hope for good discussion amongst the team. We know quite a few people in the audience are working with Africa Healthcare Network, so this will be a nice update for you to hear about the pilot program we're doing in Kenya. And if you're not a staff member or colleague with Africa Healthcare Network, this will be an opportunity for you to learn a little bit more about what is kidney supportive care and how could you consider introducing this concept and this model in your work. So today we have an opportunity to again share this overall update and insights into the program that we've been offering and piloting since 2024. By the end of this session, we hope that you will have had a chance to understand the insights of the program that we've been piloting here in Kenya. We also hope that you'll learn about the patients and families that we support currently through some great case examples, and then also be inspired to begin applying these aspects into your work as you take care of patients with chronic kidney disease. We have had an opportunity to document our kidney supportive care team. So here you'll see Cillian on the left-hand side there doing a kidney supportive care visit in one of our clinics. And then Nixon Kiprono in the white shirt there standing with some of his kidney supportive care team colleagues in one of our clinics. And we are very honored each and every day to be taking care of some incredible patients. So we also want you to remember them as we share this information today. So we started the program in 2023 in December with some basic implementation of training and started with a needs assessment of what are really the needs of patients with chronic kidney disease in Kenya and patients that are being served by Africa Healthcare Network. What is kidney supportive care? You may not have ever heard of this concept. We hope if you work with Africa Healthcare Network, you've heard of it before because we are advocating for this service. But it is really the active care of patients living with advanced kidney disease and their families who are on dialysis, really in any sort of modality of dialysis. And this type of care really focuses on improving the quality of life through holistic symptom assessment and management, as well as compassionate communication. Kidney supportive care is offered in a variety of domains. So the first and foremost is symptom management. We offer physical, psychological, and spiritual symptom management for our patients. We also offer communication through prognosis sharing or sharing of difficult news, as well as shared decision-making and advanced care planning. We know that this type of care is essential to be given as an interdisciplinary team. So when we develop our kidney supportive care team, we have our specialists, our palliative care nurses, dietitians or nutritionists as well. Considering that kidney supportive care also can include comprehensive conservative care, this is really quite important to remember as we maximize quality and quantity of life for our patients. And we for sure include end-of-life care, considering referrals to hospices and bereavement support for our patients and families. A few really exciting milestones we wanted to share. In December 2023 is when we started the program. So I started with Africa Healthcare Network and looked at some programming, which really focused on training back in 2023. In January to March of 2024, we kicked off our first kidney supportive care champion cohort. And we did new hires training. So the dialysis nurse training that we offer at AHN, we also included kidney supportive care 2-day workshop during that event, that training program. In July 2024, we were really honored to hire our first 2 new kidney supportive care regional nurses. And they are specialists in palliative care trained, and they began working in AHN centers in Nairobi and Western region. And of course, as we've mentioned earlier, they're on the call today and we'll be sharing more information shortly. August to December 2024, we did our direct patient care. So we started a hub and spoke model of care where we worked with our champions. At that moment, we were calling them champions, and now we have been calling them our kidney supportive care clinic leads. So this is where we developed documentation tools and assessment tools and began providing direct patient care to patients and families in our clinics. In January, we've had an opportunity to onboard more clinics in the Nairobi and Western region. And currently, as of March 2025, we have 13 clinics enrolled in the program. And our goal is to expand the program to the central region as we continue to analyze patient outcome data and continue to provide really high quality care. So this is what you will see. This is our hub and spoke model. So we have our program lead and our regional nurses that are kind of the main team leads. And then within the spoke model, we have our different clinics. So we are currently offering kidney supportive care at Jama, Uzima, Kikuyu, St. John's, Avenue Broadwalk, St. Mary's within the Nairobi region. And within Western region in AHN, we're offering care at Mumias, Kijabe, Liten, Kaimosi, Nakuru, Homa Bay, as well as Kisumu. And you'll probably notice a few of our colleagues that are on the call today, really excited that our team is growing. So we now are a team of 17 individuals with Dr. Yuri as our medical director. I'm the program lead, Celian and Nixon are our regional nurses, and then we have 13 clinic leads, which is great. We meet on a weekly basis on Mondays where we have team meetings. We talk about different kidney supportive care topics, teaching topics, as well as case discussion, which is a really great way for us to continue to learn and support one another. As of this month, we have had an opportunity to onboard over 280 patients into this program, and we've done over 820 follow-up visits, which is really, really amazing. We've done approximately 15 family meetings each month in the Nairobi and Western region. And really, this is where we have the opportunity to understand our patients more and really support that shared decision making. So here you can see I've shared some information and data that we've offered in the months from August to February for our onboarding. We were working really, really hard August, September, October to bring new patients into the program. As you can see, November, December, we focused on follow-up visits with our patients, but continued to onboard several patients throughout the end of last year. And now we continue in January and February to include new patients into the program. We have continued to hold training as kind of an integral part of this program. So in 2024, we offered through this modality on Thursday evenings, once a month, a fireside chat that was really focused on kidney supportive care. So we had experts from around the world speak about different topics focusing on kidney supportive care. We also offered internal training through 33 IACO sessions for our AHN staff. And this year, we're continuing to offer those for all of our AHN nursing staff. So we're really excited that this is really a key part of our work. We already have completed 5 new hire trainings. So within AHN, we have an internal training program to increase capacity of our nurses to understand and learn more about dialysis. And it's been critical because we've had the opportunity to offer a 2-day workshop on kidney supportive care, where we've been able to support approximately 100 new AHN staff to learn about what is kidney supportive care and consider applying this approach to the work they do. So in total, this has been over 125 hours of training focused on kidney supportive care in the last year, which we're really, really excited about. In December, at the end of the year, we had a chance to do a patient satisfaction survey, and we were blown away by how our patients were overwhelmingly satisfied by the services we offer. So you can see here on the right where we asked patients about the professionalism they thought of our team, how we responded with an empathetic response, how we offered support in responding to their symptoms. We've informed them, and using a scale of 0 to 10, we've got just overwhelmingly positive results of how patients are feeling about our program. To the point, the last one I've highlighted here is that 9.7 out of 10 patients of a sample of about 63 patients highly recommend kidney supportive care to others within AHN. And we're really, really proud of this. So our patients are telling us that they want these services and they would consider suggesting it for their friends and other patients that have dialysis. What did they actually say? So part of our satisfaction survey, we asked them if they could share some comments. So one patient said, since I've enrolled, I felt much better because most of my questions that I wanted answered were provided. My distressing symptoms have improved since I met the kidney supportive care team. They've really worked with me on my journey to improve my health. And then the last one was, I've had severe pain and they prescribed me medication. They provide psychotherapy and a way to cope with my pain. Of course, with any satisfaction survey, we also asked how we could improve the program. And we heard really great information from our patients, and we're considering incorporating this into our work in the future. Patients shared with us that they'd like to avail of free pain medication. They should have analgesics available because pain is a common distressing symptom. Our patients did share that privacy is a challenge. They shared that they needed a room for the session and that having a room for more private conversations would be helpful. They also shared with us that family member involvement, including home visits, were requested, and even support groups. So these are things we're considering as we move forward with this program. As we consider symptom outcomes, we analyzed a small sample of our patients, and over time, from our initial assessment to follow-up visits, you can see here, we have been able to improve pain over time with follow-up visits. Of course, we know that many of our patients have been on dialysis for many years, and with the progression of chronic kidney disease and end-stage renal disease, we know that symptoms can continue to be a burden. But we're really positive that through assessment of pain for our patients and offering management and offering medications to support patients in a holistic approach to these symptoms, we can really improve patients' outcomes. This same sample, we had about 5 family meetings that were done. And unfortunately, since August 2024, 5 of these patients within this sample had died. But we are grateful that they did have access to kidney supportive care and that symptom support, despite the patient's passing away. So what do we know with all of this information? Well, we know that patients enrolled in our program are overwhelmingly satisfied by the services they've received. We are actively assessing our patients' symptoms, and we're creating care plans that are supporting better treatment of pain and other common distressing symptoms. We've used this hub and spoke model with our regional nurses as well as our clinic leads, and we've seen it's been very effective. The other thing that we do know is that currently there are not other dialysis companies that are focusing on kidney supportive care the way we are at AHN. And we're really, really excited to be leading the way in this effort. We are excited to be learning with others. So if this is something that you are also quite interested in, please do get in touch with us, and we'll be sharing our contact details at the end of the session. So you might be curious, how can you get involved? We also want to inspire our colleagues here in the region to consider this approach to care. Well, if you are an AHN staff and you're listening today, and maybe today is the first time you've heard about this program, you can refer patients into our program. So we have a referral program where we ask that you consider screening patients that have at least two of the following. Patients over the age of 60 who have severe or uncontrolled pain, severe or uncontrolled symptoms. Maybe they have a psychological concern or social concern. They may even have advanced disease, including other comorbidities, maybe advanced cancer or other neurological diseases that might consider a good referral. A patient that has a declining functional status or frequent hospitalizations will also be a really good candidate for our program. And we know you already within AHN are referring, because since August to December 2024, we mentioned our total kind of onboarding. Well, we onboarded over 150 patients, and in 2025 alone, we've already onboarded 120. So we do know that this referral program is working. At AHN, we also have developed some resources for patients and families. So if you are aware and you've seen some of our resources in the clinics, you can take time and read them through with patients. So we currently have an introduction to kidney supportive care brochure that's available in English and Swahili. This is for our patients and families to better understand what is the service we offer and what are we focusing on. We also have clinic posters, again, in English and Swahili that we developed to continue to raise awareness of what is kidney supportive care. How are we here to support you, and what can you expect during your visit? And then in all of our new onboarding packets for new patients that are coming into AHN, we've created a small flyer where, again, it shows what is kidney supportive care. How can you be supported, and what could you expect? Again, these might be patients that would access kidney supportive care, but finding ways to continue to grow awareness of the program. Again, this is also offered in Swahili. If you are joining us tonight and you are outside of AHN, we would suggest that you learn more about what is kidney supportive care. So at AHN, we have a beautiful resource on YouTube. So our Fireside kidney supportive care chats have all been uploaded from 2024 onto the YouTube channel for Fireside chats. So there's 12 modules that are focused on kidney supportive care with expert teachers and trainers. We also have uploaded our 12 adapted and modified teaching modules that are for all of our internal staff, and we've made that freely available to anyone interested in learning about kidney supportive care. You'll also see that there on the link that I've shared. We would encourage you also to look at the International Society of Nephrology. They have several modules that are free that focus on kidney supportive care and conservative kidney management, and would highly encourage you to consider thinking about taking those modules. And again, sorry, the numbers are off here, but palliative care resources are also really helpful. So this is a free palliative care toolkit, and you'll see here the link is there. So in conclusion, what we want you to know and get out of today is that kidney supportive care really is an essential service that patients and families need as they continue on their journey with chronic kidney disease. We at AHN are really excited that we can offer holistic symptom management and a compassionate approach to supporting patients and families. And we know from the last several months with this pilot program that a hub and spoke model really offers this scalable and sustainable way to offer these types of services. So really, really excited to be here today to kind of share this update with everyone. And now we're going to shift over to hearing some case examples from the field from our kidney supportive care regional nurses. So I'm going to pass it over to Celian, who's going to take us through a case example from her region. So over to you, Celine.
Thank you so much, Erin. Good evening, everyone. I'm so happy to be here to share the cases I've experienced for the last few months since I joined AHN. So since August 2024, I've been able to interact with patients within the Nairobi region. I've done a bedside pain and symptom assessment and management, and I've also been able to offer psychotherapy to my patients in my capacities through showing empathy, through active listening, as well as having serious illness conversation with the patient. So I've also had an opportunity to mentor my KSC clinic leads, that is the nurses and clinicians in the centers, and they have been able to do follow-ups even when I'm not in the clinic. So they have been able to take care of the patient when I'm not away, or while I'm not at the clinic in the present. So I'm going to share a case example from the Nairobi region. So about this patient, we have a 32-year-old female patient who was diagnosed with end-stage renal disease on April 2023. Other diagnoses include diabetes mellitus, which was diagnosed in 2019 after delivery of the firstborn. She was also diagnosed with hypertension, which came in as preeclampsia on April 2023, but unfortunately she lost the child in the process of the preeclampsia. On an educational background, this is a patient who is on a secondary school level. Occupation prior to the illness, she was a business lady, a tailor before the illness. She's married with 2 children. On the family history, she has a brother and a sister who live in the rural, but are very supportive to her. The current living situation is she lives with the husband and the children. On the medication history and the vital signs, she's on nifedipine, 40 milligrams twice a day. She's on carvedilol and Lasix, atorvastatin, hydralazine, and Mixtard 20 international unit during the morning and 18 international unit in the evening. She's also on bi-weekly hemodialysis. On my assessment, the vital signs, the BP was 196/84 and a pulse rate of 81 and the weight of 53.7 kgs. She was alert and well-oriented, and lungs and heart sounds were normal, and there was no evidence of abdominal distension or any mass. So one of my work I do is symptom assessment, and we use the SS renal scale, and we were able to do a symptom assessment, and the patient reported pain on a scale of 5/10, and epigastric, the pain of 5/10 was on the left lower limb, and epigastric pain was at a rate of 3/10. Other symptoms included tiredness, which she rated at 5/10, and nausea at 4/10. She had a little bit of mild depression at a scale of 2/10, and trouble sleeping at a scale of 3/10. Other symptoms, she had headache, intradialytic, and she rated it at a scale of 4/10. All other symptoms like drowsiness, lack of appetite, anxiety, itching, well-being, and restless legs was at a scale of 0/10. So she was able to explain her symptoms and was able to rate it at a scale of 0/10. On psychosocial concern, this is a patient who had an overwhelming worry of feeling constantly sick. She had a loss of independence, which made her stressed, and she felt like she's a burden to her husband. The feelings of sadness and crying was throughout the session, and the patient verbalized of giving up to a point of even thinking of taking her life. She is fully dependent on her husband, who is supportive. She has lost income due to the illness. She has financial constraints. And on the side of the family history, the siblings are able to support her where she can't. On communication and spiritual concerns, this is a patient who was able to speak fluently with no slurring speech. She was expressive of her emotions, displaying feelings of sadness and worry. She had also feelings of hopelessness and despair. At a point, she even questioned the meaning of life when she feels sick and can't take care of her children. She verbalized stresses of having conflict with the mother-in-law who keeps seeing the illness as a spiritual problem. On the church history, she used to attend church, but currently she doesn't attend anymore. So part of our symptom assessment, we do a holistic assessment, taking history on the social, physical, spiritual, and psychological history. So we come up with a plan of care, and this is what we came up with this particular patient. So we addressed symptom management during the KSC visit, including the initial visit and the follow-up visit. We were also able to manage depression by giving her medication, that is amitriptyline, 25 milligrams nocte. We also offered psychological support in our capacity through counseling and reassurance, active listening, validating feelings, and showing empathy. We also noted that the patient will keep on benefiting from constant counseling and support from the KSC team, including the clinic lead, to help the patient manage and cope with the illness. So a summary of the cases: we have a 32-year-old female patient with 8-stage renal disease, with diabetes and hypertension on medication, with hemodialysis treatment for 2 years now. Currently, she's on our KSC follow-up for symptom management and psychosocial support.
Lillian, we'll take some time at the end to do the discussions, and I'm sure there'll be a few questions in the chat. So we'll pass it now over to Nixon. Nixon is leading kidney supportive care in Western region. You're welcome, Nixon. Kiprono.
I'm going to take you through a small summary of a patient. I had shared the story about a case with Erin Das this week. She's a 62-year-old lady who has a primary diagnosis of end-stage kidney disease, which was diagnosed 2 years ago. Other comorbidities are DM type 2 and hypertension, which was diagnosed also in 2023 November. She was working actually in the Good Hospital. Currently, she's retired and she's engaged in small business of her own. And marital status, she's a widow who has 2 grown-up children, and they are still living within the facility. The patient was well until 2 years ago when she was diagnosed with hypertension and diabetes and started on dialysis after developing serious symptoms which led to diagnosis of kidney failure. She's doing the dialysis twice a week. And when she was diagnosed, that is the moment we met and we had the initial assessment. And the most things which came up was actually financial issues and family upkeep, since none of the children was financially stable. And I did what we usually call initial assessment. As for us, mostly the first thing what we do when we meet patients is initial assessment, which means we do family assessment, issues, financial, psychological, spiritual, and everything else. There were a lot of problems which we kind of handle it, and let's move on to the next one. Since she was hypertensive, she was put on nifedipine 20 milligram PID, and for dialysis, she's doing it twice a week. And those are the physical blood pressure, pulse, and weight during the initial assessment. At that moment, she was alert, everything was well, except that she had epigastric pain. And she was diagnosed with the clinical officer who is there in Lugulu that probably it was it was ulcers after taking the blood for they measure blood for ulcers, and they prescribe actually H. pylori kit, and the pain was when we rated the pain, it was 6/10, tiredness 5/10, drowsiness 0/10, nausea 5/10, and lack of appetite 4/10. Depression, we didn't notice any signs of depression. That is why we rated it at 0/10. Anxiety at that moment it was 4/10. Well-being 3/10. Eating 0/10, and trouble sleeping 5/10. There was no restless leg. Next, whatever. So psychological and spiritual assessment, she had moderate psychological distress related to change of lifestyle and financial strain as kidney support care communication was done and therapeutical communication initiated. She has been able to cope positively, that is subjectively, according to what she said, and she's a person who is spiritually and religious contented and practice religious rituals which contribute to a source of hope. So on that day, we didn't notice anything to do with spiritual pain. Next, what was our plan of care? After discussing with the team, we have a clinical team on the ground who is the clinical officer. We have nurses and me as a team member who is a palliative care nurse. We sat down because we saw actually this is a patient who need holistic care and we need to discuss a lot of things. We sat down and with collaboration with the team, which is on the ground, we managed to come up with a plan of care. So we prescribe paracetamol, 1 gram thrice a day, H. pylori after taking blood for H. pylori test, which came up positive. She was vomiting and she had nausea. So the clinician prescribed that H. pylori kit. I did psychological counseling, which was more of psychotherapy communication. I shared most of the information with her, or mostly she was not aware about the disease progression, and I shared with her. And there were a lot of decision-making assistance since she was a retiree from the Lugulu Hospital, and she had to transition to go back to her home, which is not far from Lugulu still. So we had to discuss about that. And also, since Lugulu, we still don't have somebody who is taking care of, as in kidney support care champion. I gave a mandate to the clinical officer who is there to weekly monitor and then give me the report. And last week, when I reported back, I saw a lot of changes, and also the nutritionist has been also following up with her. So that is about that patient. Whatever in the last month, what we found out, and up to date, how she's doing, I can say there's a lot of changes. There's a lot of difference. So that is it, Erin.
Great, thank you. Yeah, so for these 2 patients, you can see with some basic investment in assessing first and then addressing the symptoms that are of most concern to our patients, we have been able to see improvement, and we are really, really excited. We have a few questions to put towards the group, and would love to take some time to reflect on these together. So the first question is, how can we as a supportive care team come up with ways to provide social support, even if we have limited resources. So we may or may not obviously have extra resources to offer to patients. What are other things we can do to support them? Second question is, what are some ideas that we as a group can come up with to develop potentially support groups for our patients at a center level? And then the last question is, offering pain management along with psychosocial support can really improve the overall well-being of our patients. What are some other interventions that you could consider or that you find helpful in supporting patients, especially those that have high symptom burden? So we talked about a few different symptoms tonight. What are some things that your teams are doing? We this evening have Cillian and Nixon, who every day, day in, day out, are supporting patients. So they are definitely going to be our experts here as we reflect on some of these questions. So happy to hear some comments from the group, or you're welcome to put a comment in the chat. And then we're also here to answer any of your questions.
Thank you, Erin. I think as the participants, putting the answers in the chat box, just allow me to proceed to the Q&A so that we can take up a few questions as we are waiting for the participants to put in their answers in the chat box. But again, feel free to just raise your hand in case you want to speak, so that we just give you just unmute you so that you're able to speak. But again, thank you, Erin, Cillian, and Nixon. It was quite an enlightening presentation. It was good to see the journey of kidney supportive care from when it started, looking at also the impact that it has had to our patients. And it was also good to look at the cases that I think the teams have handled on ground and how the patients are progressing so far. So I'll just take one question from, I think the first question is from Naomi. She's one of our regional operations directors. And she asks, how do you achieve balance between onboarding new patients and making follow-ups? I know it's a tricky one, but you can answer. How do you juggle the two? Yeah.
I'll quickly make a comment, but then I'm definitely curious to hear Cillian and Nixon's comments. We, as we have been piloting the program, we also are learning. What can we handle? How many new patients can we take on? At the moment, we're still kind of deciding what are our monthly targets in terms of onboarding new patients. The way that we have done our new initial visits for patients is having Cillian and Nixon, who have specialized training in palliative care, to do all of those initial visits. They are much longer visit. They can take anywhere between 30 to 45 minutes to do that full assessment, as Cillian and Nixon mentioned, looking at the physical, the emotional, psychological, and spiritual issues of patients, really getting a good background of their family history. And again, this can take time. Initially, when we started the program, obviously most of our visits were like that. And then we would plan for monthly follow-ups. But yeah, we're also learning how to balance that. But passing it over to Cillian and Nixon, who on a daily basis also need to manage that. How do you guys manage that?
For me, I use the referral criteria when onboarding a new patient. That a new patient need to fall in our referral criteria for high to see high and maybe start a care plan. And on follow-up visit, I liaise with the KSC clinic leads, that is the nurses and clinicians in the centers, and they're able to make a follow-up. If we are doing pain management, they're able to report if the pain is reducing or is still there and what we can do more for the patient. So we balance the onboarding of new patients through our referral criteria and make sure that even after doing the initial visit, there is follow-up even when I'm not at the clinic by the clinic leads.
Thank you, Cillian, for that. And also, Erin, for your reactions. I think also to note, this program is a bit new, not just in Kenya, but I think probably in East Africa and even Central Africa. And many parts of Africa, we do not have such a program on kidney supportive care. I think there are a lot of things that the teams are learning as they go, and being trendsetters, I think there's a lot to share and also a lot of notes to compare with, other countries that are also running a similar program. So good job, Erin. I'll just pick on the next question from Anne Starling. Question is on why is patient 1, I think on the first case that was presented by Cillian, only dialyzing twice a week? Will symptoms not improve with 3 sessions a week? Maybe just allow me to answer that on behalf of Cillian, because I do know the landscape of Kenya. So we do have what is called a social health insurance fund. It's a national insurance fund from the government. And unfortunately, it only covers for 2 sessions a week for patients on dialysis. And yes, on maintenance hemodialysis. If a patient requires any additional sessions, either 3rd session, 4th session, then they do pay out of pocket. So the ones who can afford are able to do 3 sessions a week or even 4 sessions if needed. But currently they do 2 sessions because that is what is covered by the national health insurance. So we would hope, and I think also pushing and praying that this will be revised upwards to some point, that we'll get more sessions being covered. But I think that's why you see more patients in Kenya do only 2 sessions a week, just to answer that question. I think next question was posted by, by Dr. Maza. I think his question was on planning to expand this program to other cross countries, I think Tanzania, Rwanda. Just asking what is the plan on that? I know this is a pilot program, but I know in terms of the larger scheme of things, we are hoping that it will be at least move to other countries and be able to scale up. So Erin, your response on this?
Yeah, definitely. I mean, learning how to do symptom management is possible. We've proven that with access to some special modules that are adapted to a specific context. We've shown that we've been able to build the capacity of our 13 clinic leads. So I think the ability to scale in other places is definitely possible. It does take time and investment to increase that capacity. At AHN, we've developed our initial and our follow-up kind of documentation form, and I think those things would also be easy to use in new clinics. In Kenya, we are really fortunate that the foundation and the concepts of palliative care and the fact that we have nursing programs where you can get a higher diploma in palliative care as a nurse or as a clinical officer are not something I want to underestimate, though. So I do believe expansion to other countries in our nearby, and of course within AHN for sure, but even if people are working in countries where AHN isn't currently working, scaling kidney supportive care is definitely possible. To train dialysis nurses and to train nephrologists for sure, it is possible. In Kenya, I'm really fortunate. Obviously I'm based in Kenya and I have the honor to work with really amazing palliative care staff. I think that's something we don't want to underestimate. But again, I think we've shown in the last several months, we've been able to build the capacity of our general staff. And yeah, that part is quite exciting. We did do a bit of a cost analysis, Dr. Yuri. I think you were part of that. It is not the expertise of myself as a trained nurse to know all those details, but we have realized that with some basic investment in this program, it is again possible to scale.
Thank you for that. I do agree. I think it's a very good value proposition for our patients, and also looking at the impact of supporting our patients just beyond dialysis, also looking at other chronic symptoms, I think is a very noble program. I think that also answers the question from Mirawi, who I think the question is on whether the program is in Ethiopia, and asking if you plan to expand the pilot program to Ethiopia. Maybe to answer you, Mirawi, we are not, as Africa Healthcare Network, we have not gone into Ethiopia yet. Still expanding to other countries slowly. Maybe that will be, we can probably look at it in future, but at the moment, we are not in Ethiopia. But soon, probably, if we were to expand, we'll probably go to first other countries in East Africa and then slowly move out from where I sit. Next question is from, I think, an anonymous attendee who I think has indicated that they do believe that kidney supportive care will be more successful if the family and society will be engaged. Question is, what strategies do you use in making sure we include family members throughout the treatment process, especially those who have been abandoned by their families due to past family conflicts? Example, a patient was not there for the family. Good question. Erin, over to you.
Yeah, just a really quick comment, but then love for Nixon and Celine to answer this. I think with the kidney supportive care program, the way we've developed it, we have dedicated time to spend with patients where our regional nurses are not the ones that are providing dialysis to patients. I think having someone within the clinic that is dedicated to supportive care can be really, really effective. I know Nixon and Cillian plan many family meetings. Not all of them can happen. Again, as you've mentioned, some families are not as involved. But I think offering this to patients and families is something that kind of goes above and beyond. They may not expect it, but we need to help advocate for patients to ask for it, to find ways where we can bring patients and families together and almost mediate some of those issues. We will not, of course, be able to solve all of our patients' problems. But I think giving them the opportunity to talk in a safe environment about how they're coping can be really effective. But passing that comment over to you, Nixon, do you want to take that one?
Yes, that's a very nice question. Actually, most such kind of cases usually come up, but we usually take each and every case, we individualize, because autonomy of the patient usually come up, and we usually follow each and every case as an individual case. We don't generalize. We don't have policies which actually dictate that every kind of a case should be handled in a direct way. But we listen to what the patient says. If he or she never there with the family, we know how to handle such kind of a cases, as in those are psychosocial issues, and we listen to what the patient says, how the family take the matters in their own hand, and we usually consult. The team on the ground are the people who knows the patient much more than anybody else, and we usually do collaboration. We talk together, we come up with decision, and then we see how to manage such kind of cases. It's more individualized.
Thank you, Nixon, for that reaction. Thank you also, Erin. I think in the QA, there are a few answers. Just responding to the questions that you have posted, Erin. Should I read them out, or you can take the question? You can read the answers out. I think the first one is from Mina, answering Q1. Maybe allow me to read it because I can see it on my screen now. So Mina is answering question 1. And she's indicated that creating peer support groups, which will enable patients to connect with others with similar experiences, which will lead to emotional support. Answering the question on how can we as a supportive care team come up with ways to provide social support using limited resources. Yes, so for our answer is to have peer support groups. Then I think there's a participant who indicates that she had missed, or he had missed a major part of the presentation, but has seen the reflection question and will feel like a co-designing approach, possibly using HCD, might help in developing an intervention prototype to support care.
Yeah, I think this concept, so I think HCD would be human-centered design. I think this is really critical to the work that we do in supportive care, where we have the patient inform us of what they want to see in the program. I think we as a team probably could do this more often to inform the full program, not just their actual care. But I think it's a really good point, ways to get our patients and the receivers of our care, or the users of the service, to really inform the care. I think that's, yeah, a really good idea.
I think that was from a participant by the name of Emmanuel. So that is the last response that I've seen. No other questions on my end. No comments. Yes, but feel free to, in case we have any additions from the panelists, feel free to unmute yourself. If you have any questions, you can ask, or any other comments before we close.
I think I should thank Erin, Celine, Nick, and yourself, Yuri, for this wonderful session and all the progress that you all have actually, contributed to. It's a great initiative, and I think this will definitely spread across Guinea and other aging centers, especially now. What you all have actually talked about: symptom management, advanced care planning, and shared decision making. The psychosocial and emotional support that was mentioned in the cases. And of course, there are the other considerations of end-of-life care, ethical consideration, then the holistic and multidisciplinary approach that we would actually present. So thank you so much. It was a wonderful presentation. Thanks, Erin, for his leadership, and I think a great job that's done. And thanks, Yuri, for all the support that you have been giving them. And great job, Celine and Nick.
Thank you, Dr. Lloyd. I'm seeing Carlos. Carlos, you want to say hi?
Yeah, hello. I appreciate. Thank you, Erin. It's exactly that we are looking for and working together to provide the holistic treatment for the patient. Thank you.
Thank you, Carlos. Thank you, Erin. As I'd mentioned, it was quite enlightening. It's a very novel program. And again, I know Erin and his team have really worked really hard to try and figure things out because there's no, I can put it, no blueprint to go about it. And as they figure out things, they're doing so using, what they're learning from patients, what they're also learning from the patients' caregivers, and also from even staff who take care of the patients. So we'll be more than happy to see the program grow, for it to scale, for it to go to many countries. And hopefully, Erin will come back, teach us more, give us more progress, so that we are able to learn more about kidney supportive care and the good work that she is doing, just starting in Kenya and hopefully to paint the rest of Africa and the world. So on behalf of Africa Healthcare Network and our panelists, I want to say thank you to all our participants for joining this session. Hopefully we'll see you again next week, Thursday, same time, same place. This particular discussion will be posted on our YouTube channel for the people who are not able to join in time, so that you can go through it at your own time. And for now, I want to wish you a good evening, and see you next time.